So obviously the estrogen levels decline to almost nothing, and so does the progesterone. That's sort of the definition of menopause. Diagnosis first, then a plan, and then the plan has to be tailored, of course, to the patient, to their symptoms, whatever they might be, to their concerns, to their budget.
Welcome to our special mini-series on women's health, hormones and menopause, launched in conjunction with World Menopause Month. This special series of episodes is dedicated to uncovering, understanding, and acknowledging the multifaceted aspects of midlife health through the lens of expert opinions and science-led treatments. Each episode aims to elevate the conversation around safe and effective healthcare for women, focusing on deepening our knowledge and recognizing the unique and profound challenges women face during perimenopause and beyond. I'm Bahar Etmanen, the host of Ageless by Rescue podcast. Join me as we tap into a wealth of expertise from leading medical and allied health professionals, exploring a range of topics from hormonal optimization, sexual function, aesthetic beauty, and cellular wellness. My goal is to empower listeners with the information and expert insights they need to navigate menopause with confidence and optimal health. This series is also a great way to spark conversation with your healthcare provider and to share with employers, partners, friends, and family to help better understand the peri and menopause changes and challenges. I invite you to share these conversations and make them your own. Today, I'm joined by Dr. Ritu Gupta, a distinguished specialist dermatologist from Platinum Dermatology in Sydney. Dr. Gupta holds an M.B.B.S. with honours, a PhD and a F.A.C.D. qualifications, and brings a wealth of expertise in medical, cosmetic, and surgical dermatology. Dr. Gupta's extensive research into skin health, particularly her groundbreaking work on vitamin D, make her a perfect guide for understanding how hormonal fluctuations during perimenopause and menopause can impact the skin. Today's episode will cover everything from the role of estrogen in maintaining skin collagen and elasticity to how hormonal disruptions can lead to conditions like rosacea, increased pigmentation, and changes in skin texture and moisture. Additionally, we will tackle the topic of Ozempic face, discussing the unique challenges that rapid weight loss poses to skin laxity and overall skin health. We'll explore the specific skin challenges women face during each phase of perimenopause and menopause, including the often-taboo topic of genitourinary symptoms and their effect on everyday comfort and confidence. Join us as we uncover why this transitional period in a woman's life can be particularly challenging for skin health and learn what steps can be taken to maintain and enhance skin integrity and appearance during and after menopause. Dr. Ritu, how good to have you on the show. I've been lucky enough to be your patient a few times, and now, and we did an interview before, but now I finally have you on the show, and we're talking about a topic that you're very passionate about as well, which is what happens to our skin during peri and menopause.
Mm-hmm. Yes, absolutely. Well, lots of things. So, I think that it's really been an underexplored area in medicine. And I think menopause, the time has come for menopause to come out of the shadows. Not just with skin, but obviously just generally with bone health, with muscle health, the genitourinary syndrome of menopause. So I think actually it's a constellation of things that has come together. And women spend a third of their life, more than a third of their life, in the postmenopausal state. So it's a really important time. And I think we as medical professionals, as specialists, need to be aware of all the changes that occur and how we can manage them, how we can hopefully prevent some of those changes from occurring.
One of the reasons I really wanted to have you on the show to discuss this topic, which is part of a mini series I'm doing, because I felt like, exactly as you said, menopause is out of the shadows. This is a conversation that we need to have, to your lovely, eloquent way of saying it. It's a constellation of things that we need to discuss. And skin is one of the first things that you notice dramatic change when you're going through peri and then post-menopause. And For me, it was really important to have a dermatologist who is, completely focused on skin. Dr. Ritu, let's talk about the physiological changes as the hormonal changes of perimenopause and menopause hit the body. What is the effect on the skin?
Okay, well, that's a big question, big topic. Lots of things happen. So obviously the estrogen levels decline to almost nothing, and so does the progesterone. That's sort of the definition of menopause. And with that, particularly with the dramatic reduction in estrogen, we see a lot of changes in the skin. So we see a loss of 30% collagen within the first 5 years of menopause, which is terrifying, quite frankly. After that, it does sort of settle down and it reduces to about 2% loss every year. This is in the absence of any HRT or any intervention. We also see, because of that reduction in estrogen, we see thinning of the skin. We see skin dryness because we see our ability of the skin to hold water reduces because of lack of estrogen. We see a reduction in wound healing because estrogen also promotes healing. We see an increase in inflammation. We see what's called vasodilatation, so opening up of blood vessels, often the first sign of perimenopause when people get hot flushes. We see loss of elasticity. So, we talk in dermatology about something called skin turgor, which means that mine doesn't do it, fortunately, not yet. But if you pick up the skin and it sort of stays up, it tense because of thinning of the skin and loss of elasticity and loss of what's called skin turgor. We also see a reduction in the thickness of the skin. So the epidermis, the upper layer of skin, becomes thinner. So unfortunately, from a skin point of view, there's not a lot of good news about menopause. There's also changes in the hair. We see thinning of the hair. We see something called senescent alopecia, which is kind of old age hair loss. We also often see female pattern hair loss. We see loss of color in the hair. We have changes in the muscle. We have changes in the bones. I mean, there's a long list.
It's really interesting because one of the things that I learned in seeing you at your practice is that a dermatologist speaks to so many aspects of the skin and the body. You treat hair loss, you treat laxity in body skin, body muscles, and I think that that's a really interesting thing to get your perspective on all the physiological changes that
Mm,
present as the visible signs of aging, not just in
yeah,
the face, but also the hair, the body, the musculoskeletal system, which is, responsible for holding up the skin, I guess.
true, true.
And
Well, look, I suppose in Australia, dermatologists have not really embraced is probably not the right word. I don't even know if it's a conscious thing, but certainly our US counterparts and dermatologists in Europe do a lot of management of the body. So not just the skin of the face, but the skin of the body, but also increasingly muscle and things like the pelvic floor. And in Australia, I'm probably one of only two dermatologists who are doing those treatments and who are interested in that. But I think it will be an increasingly it will be a growing part of both skin health, body health, generally what we call our health span, allowing us to not necessarily live longer and be sick. No one wants that. We'd all rather drop dead. I mean, if you asked anyone, you don't want to save yourself for the nursing home. But what we want is a healthier life, a health span. So absolutely, I think that looking at all of these are really important conversations, both obviously for women in postmenopausal, but for men too. Everyone is living longer. So we
and I
need to
think
look
to your
after all of
point,
this.
um, the conversations that we can have with a dermatologist and the questions we can ask our dermatologist go beyond what happens with skin damage or sun damage or cancer. And we can start talking about, as you said, health span of the skin,
Hmm.
but also what I like to refer to as beauty span of the skin, because we are acting younger, we are living longer. It's not a joke when people say 50 is the new 30, because,
Mm.
you know, 30 years ago when you were 50, the way we were portrayed in the media, the way that
Mm.
of what our opportunities, for the way we dressed, how we presented ourselves have really
Mhm.
changed. And so women
Absolutely.
in particular are
Mhm.
looking for ways to extend their beauty span along with their health span and their life.
Absolutely. And
And
sometimes sorry, sometimes it's not even about beauty, it's about relevance. And so many, and it's an unfortunate thing, but, women are still much more greatly judged on their appearance than men are. Men just get to look sort of, they get to look serious and have gravitas if they look old. But I see so many women, corporate women particularly, who say, look, I'm in a room full of 30-year-olds and I can't afford to look old, because if I look old, people think I'm past my use-by date,
it's really
which doesn't
interesting you
happen to
should
me.
raise that. It's so funny you should say that, because I think it was this week that GQ launched a cover and a video with Brad Pitt and George Clooney. And the world has gone crazy for it. They've created this mini film of the two of them in the countryside, you know.
Mm.
So,
Near
and I'm
George's
wondering,
villa in Lake Como, probably.
okay, so, and I'm wondering, do we have a female equivalent of a cover with two women in their 60s who are
Mm.
still regarded as sexy, as potent, as vital, as beautiful, that they could carry, a September issue or a cover. And I thought, to your point of what you said, there is this assertion of wanting to remain relevant physically, but there's also that point that you made that, we also want to look healthy. We also want to support our skin health. And you mentioned one of the symptoms of when estrogen and progesterone exit or decline rapidly is inflammation. Now, I'm wondering if you could speak further to how that impacts the skin. What does that look like?
Well, we can certainly see an increase in some inflammatory skin conditions. So rosacea is a big one that will often flare in the perimenopausal state, particularly because of all that opening up of blood vessels, vasodilatation, that can really drive rosacea, so flushing and blushing. We can see pigmentation in the perimenopausal sort of phase, where you can have sort of spikes of estrogen, because estrogen does tend to cause pigmentation. So lack of estrogen, one would normally think, would actually reduce pigmentation and things like melasma. But I don't think we have the exact answers with the science yet. But in some countries, 80% of the women who have melasma are actually postmenopausal. So clearly, there are other factors other than estrogen as a driving force in that. In terms of other inflammatory skin conditions that can worsen or present often in menopause, things like genital lichen sclerosis, which is a pretty uncommon condition, and you may not have heard of it. It's basically an autoimmune condition that classically affects the genitalia. It's can be really debilitating for women. It's dryness, it's tightness, it's a scarring condition of often the vaginal area, the vulva. Women can their whole clitoris can be completely obliterated by this. And if it's not treated, actually there's a 5% chance of squamous cell cancer developing within lichen sclerosis. So menopause is not a cause of it, but the dryness and the thinning of the skin, which medically is called atrophy, can mean that those symptoms can be worse. So it can be a time that lichen sclerosis can present. And often women, just like with everything, they just suffer in silence. They don't say anything. I see women who've had these conditions for 10 years and they've seen so many doctors, and people haven't even examined them. They've just given them a cream and the wrong cream, but no one's looked.
It's funny that you should bring up that topic, because another topic that I heard, I remember going to a presentation of a tech. It was a skin needling pen device. And they were saying that one of the biggest growth areas for them was depigmentation of the genital area, which they see an increase of in postmenopause. What happens there?
Well, I mean, the genitalia is classically so the genitalia, and also what are called the secondary sexual sites. So that's like under the arms and under the breast. are classically more hyperpigmented. They're darker than other skin. And that is particularly more evident in people with skin of color. So from Mediterranean skin through to my skin type, your skin type, and darker. And the darker you are, the more obvious it is. And people can certainly feel self-conscious about that. I mean, historically, there's really not been much to treat that. Fading preparations tend to be very irritating in those areas because the fading preparations usually have to contain vitamin A to get down to the layer of skin where the pigment cells or melanocytes live. In terms of whether that worsens during menopause, I'm actually not certain of the answer to that, whether that is the case or not. Certainly, it can darken during pregnancy because, again, estrogen and melanin have a bit of cross-reactivity. So often people will notice like their moles will get darker in pregnancy, and other things will get darker. Melasma will often flare. But again, I think that some of these things are still poorly studied because, again, it's been in the shadows, so no one has really cared. So poorly studied, and therefore we don't really have good scientific answers to some of those questions.
The reason I ask you is, who else are you going to ask if you're not going to ask your dermatologist? And I want to one of the goals that I have for the Ageless show is to introduce the depth of specialities within the aesthetic, medical, surgical fields, because I think that we don't quite understand as consumers who to go to for what.
Yeah,
And
very
then
true.
we're surprised when we don't get the direction that we need or the answers that we want. So for me, anything to do with the skin, and as you said, globally, dermatologists are treating the whole body,
Mm-hmm.
and it's not so common here. So I wanted to ask you that question. The other thing that you brought up was the
Genitourinary
genitourinary.
syndrome of menopause, yeah.
That's it. Yes. Say it
Big
again
long
so
name,
that I
yeah.
haven't, you say it again so that I haven't bumbled it. Go ahead.
Genitourinary syndrome of menopause.
Thank you. Thank you. Thank you. It's a tongue twister. Could you share with us what some of those conditions and symptoms are and how you would potentially deal with it?
Okay, so I mean, I suppose one of the most obvious and common symptoms, and in fact, apparently 50% of women suffer from these symptoms, and again, they don't talk about it, is vaginal dryness. That's a big one. Because basically the mucus cells become less efficient with age, as do the oil glands become less. So that's one of the reasons for dryness on the skin. But the lining of the vaginal canal also, it thins. So it's more fragile, more prone to tearing. It's drier. So that means sexual relations can often be painful or not as pleasurable. People need lubrication. There's also loss of tone. So there's looseness of the vaginal wall and laxity, and that is definitely exacerbated by childbirth, vaginal deliveries, definitely. And then the pelvic floor also weakens. So the muscle layer, the sling that surrounds between the vagina and the anus, the area called the perineum, all of that can weaken, both because of childbirth, because of loss of tone, just with menopause and aging. And so all of those things have an impact that can lead to things like stress, stress urinary symptoms. They call it the key in the door. I've got to go, I've got to go, I've got to go. Sorry, I said stress. I meant urge. That's the key in the door. Or stress symptoms, where you can't cough or jump on a trampoline. I mean, I heard this story the other day when I was at a conference in the US with dermatologists and plastic surgeons. That, you have this group of women sitting around. They've been friends since school. And when they cough, they have to squeeze their legs together. And everyone has the same problem, but no one talks about it. So again, it's
No one talks about
no one
any of
talks.
this stuff. I was about to bring up something you touched on earlier, which is the changes to the hair and scalp as a result of uh, perimenopause, menopause. And it's only recent that people are even talking about graying hair, whether they want to go gray, whether they want to continue coloring their hair, or scalp health, scalp as an extension of the face. These are all very new conversations. Even 5 years ago, we weren't having these conversations. It would almost, I can't remember a time. I had my menopause 5 years ago. I did not know I had my menopause until 2 years later. I had absolutely no idea what all the symptoms were. I just felt strange. The reason I found out I had menopause is I went to my aesthetic physician and I said, "Oh, I'm getting a little bit of looseness under my neck." And he said, "That's definitely hormone related. Let me refer you to a doctor who can test your hormones." She tested my hormones. I had barely a drop of estrogen left in me. And she said, "I think you've had your menopause." And then,
Mm,
oh, yes, I thought about it. I haven't had a period in 2 years.
mm,
It's gone. And as you said, that precipitous decline of collagen had already started. So,
yeah.
but who to talk to? I can promise you 5 years ago, there wasn't this, outpouring of interest and conversation
Mm,
and expert network to tap
yeah.
into. There really wasn't.
Well, look, I think there are definitely, I mean, I know personally two very good female GPs who have an interest in menopause, and that's mostly what they do. And one GP who's in Bondi Junction, she's sort of trying to set up a network around it. I mean, dermatologists, obviously, no one knows skin, hair, and nails like a dermatologist, and that's skin everywhere, including the skin on the scalp, the hair, and to go back to what you said before, where people don't realize. I mean, it happens to me all day, every day. People go, "Oh, do you do that as well? Oh, do you do that as well?" So it is about just educating the public, I suppose, um, about what is involved and what a dermatologist does do. And I think that is a little bit of a gap in Australia that people don't even realize. They know we do acne. Some people don't even realize we do skin checks and we diagnose melanomas and cut them out and, all of this. So forget about genitourinary syndrome of menopause. That's not even going to occur to them.
No, it really isn't going to occur to them. So I think it's so fascinating, your depth of knowledge on that. And I want to go back to the hair because hair loss, hair
Hmm.
sensitivity, a rapid loss of pigment in the hair,
Hmm.
but hair loss in particular seems to confound women. It seems to be the one thing that they are willing to like cry out about.
Mm.
And
Yes, it's
I
a
think
very emotive thing, hair loss. I mean, I see lots and lots of people with hair loss, male and female. But I will say once again that often by the time they see me, they have spent countless thousands of dollars and years seeing non-specialists, which is, I think, a real shame. And it is something that needs addressing. In fact, I think I'm being interviewed for something about hair loss tomorrow. But in terms of hair loss and menopause and in the aging state, so often, I mean, there is an age-related hair loss, which, as I said, is called senescent alopecia. And there is age-related fading of the intensity of the color of the hair and then progression to grey and white hair. Um, in terms of hair loss, there are so many treatments that we can do, medically proven, scientifically proven treatments that are very inexpensive, tablets that patients can take. So I prescribe lots of, prescription treatments for hair loss that are much, much more effective. There's also a number of newer things, exosomes, which are injectable or topically applied, surface applied growth factors and cytokines for hair. And we have some new ones that are coming out in Australia, which is quite exciting. In fact, I've just been using them on patients. But that's in addition to medical management.
And
So,
what about, you mentioned that um, nails as well is something
mhm,
that a dermatologist can support
mhm,
you with. The thinning of nails, that, you always had beautiful nails and then suddenly your toes have got like little bumps in them and your nails
yes,
are peeling off. What
yes.
is happening?
Well, there is something called longitudinal ridging of the nails that happens even from about the age of 30, where people get these sort of lines along their nails. Um, Part of the aging of the nail matrix, which is sort of lives here. It's where the nail comes from, and then you've got the nail bed and the nail plate. And my nails don't look at all fancy because I wash my hands 30 times a day. So, um, in terms of thinning of the nail, I don't know that there's been any studies as to whether that is worse with menopause or not. But certainly the nail bed on which the nail plate sits is just like normal skin. So there's epidermis, which will thin as estrogen and progesterone decrease, particularly estrogen. There's collagen, there's elastin, all of that will reduce. So all that can mean that nails can be more prone to wear and tear. Obviously, there's other things, there's over vigorous manicuring, there's washing your hands a million times a day that can all contribute. But yes, so there are some things, again, that can be done for nail strength. There are certain B group vitamins that are very, very effective, that aren't expensive, that can be bought at the chemist. But again, it's just, I always come back to the same thing. The first step is a diagnosis. And you have to look at who is best equipped to make that diagnosis. Diagnosis first, then a plan. And then the plan has to be tailored, of course, to the patient, to their symptoms, whatever they might be, to their concerns, to their budget, etc.
We know one of the big things that's kind of iceberg ahead in the aesthetics field, which I know you also offer at your clinic.
Yeah.
But I guess I would like your take on it from a dermatologist perspective. The iceberg ahead is what they call Ozempic-based, which is the effects of rapid weight loss
Yeah.
and the GLP-1 medication. And I'm wondering if you could speak to what you were seeing in clinic and what you are hearing as research evidence on the impact of rapid weight loss, whether it's by the GLP-1 medication or any other like gastric bypass or anything like that. What happens to the skin in that environment?
Okay. So there are massive changes, and there's some really interesting research out of the US with the GLP-1s. And unfortunately, in Australia, we're only number 2, I think, in the world leaders in the obesity stake. So at the current sort of trajectory that these medications are being prescribed and being taken, 20% of the population will be on them. So that's 1 in 5 people. Now, 40% of the weight that people lose is muscle. So that is really, really worrying because we're losing
And that's
muscle.
not because the medication strips muscles. It's because they're not eating correctly to maintain muscle.
And just very significant and rapid weight loss.
Right.
So 14% of the loss is muscle. And the problem is, unless and that's what leads to Ozempic face, Ozempic body. And the issue is that we lose 10% muscle every decade anyway. And post the age of 60, regardless of what you do, it is almost impossible to put on muscle. So if you have a combination of being at the older end of the age spectrum plus significant weight loss, then it's like, it's like a perfect storm. And if you're losing significant muscle, yes, of course, that's going to be terribly aging in your face, because at the same time that you're losing muscle, you're losing thickness of the skin because you're getting older. If you're a woman and you're postmenopausal, so you're losing skin elasticity. So the skin is thinning. The muscle is significantly reduced. The bone also shrinks with age. So just like you get osteoporosis of the skeleton and osteopenia, which means reduction of bone, that happens in the face as well. So all of that leads to very significant aging effects. And then there's gravity as well. And then in the body,
This is not a good news episode.
Oh, I know. It is not a good news story. I mean, it isn't a good news story in that this is what happens and that this is, the prediction, particularly with these medications. But the other, I suppose the good news story is that if we can recognize it and if we can address it early, then we can actually preserve that muscle before people lose the muscle. And muscle preservation techniques, and I've actually just started a subclinic within my practice, one on pelvic health and wellness and one on muscle preservation and muscle strengthening. Because if we can preserve that muscle, then we all know muscle is more metabolically active than fat. So it means that you can keep that weight off rather than, because this is the other evidence that is coming through, that when people stop these medications, they can put on the weight like that. Now, I don't prescribe these medications, but I certainly see patients who've been on them. The other issue is if you're losing all this muscle, then you're losing your core, you're losing your pelvic floor, particularly for women with menopause. So that means increased lower back pain, inability to stand up straight, more fractures, all sorts of things that are actually medically important as well as aesthetically important. I myself have lost, I haven't been on these medications, but I have lost a bit of weight and I've lost a lot of muscle bulk in my gluteal muscles. And that's led to a hip pain problem. And my pelvic physiotherapist said to me, listen, you need to build your glutes because you're suffering from dead butt syndrome. which is
That's
apparently
what
what
I
happens.
have.
I know,
That's
it's
exactly
apparently what happens when you sit around all day, which is actually not what I do at all because I'm constantly walking between rooms and seeing patients. But anyway, there you go.
it's the strength training aspect of it. That's
So
what I'm learning about.
yeah, so I'm using devices that we have here, like M-Sculpt Neo and M-Seller, to build that muscle, in addition to exercise. But I mean, the fact of the matter is, you can't do 20,000 contractions of your abs or 11,000 pelvic floor exercises. We can't physically do that. So if we have, medically proven devices that can help us, and if we are being treated by um, practitioners, specialists, or their team who know what they're doing and who can give a combined targeted approach, then so much the better.
I think one of the things that I appreciate about the dermatologist space, which I didn't know, is I went to the Australian Society of Cosmetic Dermatologists conference in Melbourne this year. And it was so refreshing to see that cohort being very embracing of technology, of newness, of skincare, and of all sorts of modalities. And I wasn't prepared for that. And they were, really forward thinking and with deep respect for what you do. I guess I always had this idea in my head that dermatologists were too sensible to recommend the tech or the various skincare or even aesthetic treatments, but that wasn't the case at all. There is a growing interest, growing research, growing cohort of
Mhm.
dermatologists and cosmetic dermatologists too, who are
Absolutely.
embracing.
Well, I think that's probably been a change and in dermatology. So certainly there are dermatologists that are purely medical. Definitely there are. But less and less so. Most dermatologists will do some laser work, some cosmetic work. I'd probably do about 50-50, maybe even 60-40 cosmetic dermatology, so lasers, injectables, devices, and then also medical dermatology. And I quite like the mix because it's varied. And for me personally, it makes me feel that I'm uniquely positioned to be holistic. So I can be a one-stop shop. Someone can come to me for their skin check. I can diagnose their melanoma, cut out their melanoma, improve their pigmentation and, treat their skin laxity, treat their body, treat their pelvic floor. We can actually treat all components, which I think is great. And I think it is a unique feature of being a medical and cosmetic dermatologist.
I have a couple of questions that are not necessarily hormonally
No,
related,
that's
but
fine.
they are things I've always wanted to ask a dermatologist. So
Go for
I
it.
I I am asked a lot about this trend of glass skin, and I'm wondering from a dermatologist perspective, is it really possible to create that sheen and that flawless, completely even toned skin without over treating the skin with too many products, too many ingredients, too many aesthetic services?
Well, I suppose it depends what you start with. So some of this is genetics. Some people have more prominent pores than others. People who have oily skin tend to have more prominent pores. They have more acne when they're younger. There's benefits to having oily skin because the healing happens from around the sebaceous gland. So people who are oily, and I always say this is the silver lining to the cloud, is that they'll heal faster. Their wound healing is really good. Um, so partly it's the genetics you start with. So if you start with very fine textured skin with pores, if we all have pores, it's just where the little microscopic hair comes out, um, and pores that are not prominent, then that's a good start. If you have good strict sun protection and sun avoidance from an early age, that's also a good start because that means you're going to be less splodgy and blodgy with brown splodges. And broken capillaries. I mean, people with skin of color obviously tends to age less because melanin, the inbuilt increased melanin that we have in our skin is like a intracellular sunscreen. Also, what happens is people with skin of color, no one's happy with what they've got, right? So the people with skin of color always want to be white, so they stay out of the sun, whereas the white people want to be brown, so they're going in the sun. And then they reap the rewards of that when they're sort of hitting 40. And meanwhile, there's sort of people with their friends with skin of color are are remaining looking young because of not only their skin type, but also the social habits that around their racial group. So to answer your question in terms of is it possible to achieve that type of flawless or glassy skin complexion, I think it is, but there are various factors at play. So then if you've got prominent pores and if you've got a lot of pigmentation and capillaries, well, as I explained to patients, it's just physics. If you've got reds and browns on the skin, when the light hits the skin, it's absorbed. So the skin looks dull. When you don't have reds and browns on the skin, the light hits the skin and it reflects. So you look luminous. So you look lit from within. So that's the very first step, is to treat that. And that can be done very effectively with various lasers and energy-based devices. That's the first thing. And then, if you've got dips and divots in the skin, so if you've got acne scarring or if you've got very prominent pores can also be treated. Pores tend to become more prominent with age. And the reason for that, and if I just lean in here, I have my handy model that I have in every consultation. So here's a pore. This is where the little hair comes out. So all this stuff around, so this is the upper layer of skin, the epidermis. This is the deeper layer of skin. All this stuff here, this pale pink, is what's called the extracellular matrix. And that's the collagen and the elastic tissue. So as that collagen reduces with age and the elastic tissue gets all wavy rather than be this lovely firm scaffold like it is when you're younger, then the pores don't have that support around them. So the pores they haven't opened up because they don't do that. They're fixed anatomical structures, but all the stuff that's kind of holding them together and giving them the support is reduced. So then the pores look more obvious. So pores can certainly be treated. There's really no creams. There's no creams that treat pores, make no mistake. But pores can be treated by various energy-based devices, and that will certainly also help. And then if you've got corrugations, wrinkles basically, so dips and divots with lines, that's also, again, physics. The light is going to hit and it's going to cast a shadow. If you've got loss of volume, so what happens is we talk about the roundness of youth, the round baby face. That's what we talk about. And this is why skinny people look older and people who are carrying more weight look younger because they've got the fat in the face. So, and that's one of the reasons why Ozempic face is so aging, because then instead of seeing roundness, what we see is hollows. And we have light and shadow rather than light. And the skin takes the appearance, or the face takes the appearance of the underlying skeleton. So we start to see the notches and dips, which we all have in our bones. But when we're younger, we've got little pads of fat that mean that we can't see that.
Dr. Ritu, I wanted to circle back to your research into vitamin D, and because this is obviously a really topical vitamin when it comes to bone health and also skin health. And then how we get our vitamin D becomes a topic of conversation. But to finish our chat today, I would love for you to share some of your findings and your recommendations around vitamin D.
Okay, well, I did my PhD at Sydney University, and it was in a bone and skin lab, in fact. And my topic was vitamin D and photoprotection, so protection from the sun. And one of the things that I found, which then other people went on to expand upon, was that vitamin D that is made in the skin with UVB, certain wavelength of normal sunlight, can actually protect from some of the DNA damage that occurs with UV light. So certainly there is some emerging evidence that vitamin D may help with muscle strength, which, as we talked about with, significant weight loss, etc., reduces, and just general muscle loss with age and with menopause, we're losing muscle. In terms of the skin, the issue with going out and baking yourself in the sun in Australia to get your adequate vitamin D levels is that you're not just getting that one wavelength that's doing that one thing, you're getting all of the other things. And to be honest, in a country like Australia, true vitamin D deficiency is very rare. Okay, we see it really in older people in nursing homes who are not getting out at all. We see it in people who wear very modest clothing, like hijabs and things like that. But basically, the general population in Australia, what my PhD supervisor always taught was that if you roll your sleeves up and you go for a walk between the hours of 11 and 3 in the winter and you get 15 minutes of sun exposure on your forearms, that's enough for adequate
I
vitamin
wanted
D.
to ask you that. Why the forearms? Because I always say that to
It's
my
not on
daughter.
the face, because your
Yeah.
face gets enough sun already. Your face
Got
is
it.
already the most sun exposed, so that's not an area you want to expose. I mean, you could say your tummy, but it's a bit hard to walk around the street holding up your shirt. So, the forearms is easy. You just roll
Roll
the
up your
sleeves.
sleeve.
And it's just from a convenience point of view. It's not that you get extra vitamin D, formation from the skin of the forearms or anything like that.
Husbands.
Yeah, so that's why. And then if it is the summertime, you need that 15 minutes on the forearms outside of the hours of 11 to 3. And that's a very simple thing. So if most people think about that, they get that anyway. But we do have to remember that UVB is blocked by window glass. So the sun that you get through the window does not contribute to vitamin D. I mean, I would say that for someone who has truly low vitamin D, then the easiest thing in Australia is to take a tablet and still protect your skin from the sun, because there's so many other effects that we see. I mean, we're the melanoma capital, and then there's all the aging effects, the pigmentation, the loss of volume, the wrinkles, etc.
Well, that was a very interesting addition to your studies, and definitely, I'm sure it comes in handy all the time in your field of work.
Yeah,
I
it
want to
does.
thank you so much for being on the show. I think the conversation was so deep, and we touched on so many areas that, again, people listening might be surprised to learn that they can have this conversation with a dermatologist.
Absolutely.
I do want to say that, it's similar to what you said, not all dermatologists offer this broad range
That's true.
of clinical services. But where, if they're not in Sydney and they want to find a dermatologist that they can see, is there somewhere where they can find a dermatologist in their area who does have this broader, more diverse interest in cosmetic and wellness dermatology?
Well, look, you mentioned the A.S.C.D, that's the Australasian Society of Cosmetic Dermatologists, and I'm a member of that. So we have a website and there's a list of our members. So you know that if you're seeing a dermatologist who's a member of that society, that we have an interest in cosmetics, and that we will, we certainly very capable of doing the whole gamut of aesthetic medicine. In terms of whether they treat the body or not, as I said, there's only a couple of us. I think the best thing would be is to find a cosmetic dermatologist, on that website, and then have a look at their website. That's going to tell you if they're doing other treatments. But a lot of dermatologists will do treatments for skin laxity or looseness, but often that will be more sort of like on the neck or the chest, or perhaps even on the tummy. A lot of dermatologists will do treatments for excess fat. Not that many do treatments for improving muscle and muscle strengthening and the pelvic floor. That is a little bit more niche within dermatology.
And more specialist, yeah.
Yeah.
More specialist. Again, thank you so much. Absolutely a pleasure to have you on the show,
Welcome.
to have the deep, deep conversation. Thank you.
Thank you, Baha. Anytime. Lovely to have a chat.